Okay, thank you very much. I especially would like to thank Professor Mons and Heinz and Jennifer DeBarry for inviting me here to set the stage for this important conference on infectious diseases. And I think, as Professor Heinz noted, it's his first effort to take a look at infectious diseases through the lens of personalized medicine, and that is particularly appropriate, as I'll explain in my introductory talk. So my goal is to set the stage for what we're going to do in the next couple of days. And I think it's important also to know where it is I come from. As it was noted in the introduction, I represent a coalition of all stakeholders in healthcare around the world, not just in the United States, who believe that personalized medicine offers a better solution for patients and also for the health systems around the globe. And I will explain why this is the case in a few minutes. Personalized medicine is, whoops, so there we go. Personalized medicine is not new. What's new is we now have technologies to implement it. But personalized medicine was recognized as long ago as 400 BC by Hippocrates, who recognized that it is more important to know what person the disease has than what disease the person has. That insight is one I hope you will remember. It is really profound, and it's difficult, as I said, to implement, but it is the basis for which modern medicine progresses. Just a quick query. Can I get the slides showing down here so that I don't have to turn around, if possible? So anyway, that's a particular insight. Now, at the dawn of modern medicine, Sir William Osler noted in the United States that no two faces are the same, no two bodies are alike, no two individuals react alike and behave alike under the abnormal conditions which we know as disease. In other words, patients are obviously different, and when they present, the physician, the healthcare provider, needs to understand what he or she is looking at. And again, we now have the tools to do that, and not just in cancer. Or I should say, we're developing the tools to do that. And the key is to put them into place. And my brief is to explain that this doesn't just fall off a tree. That is to say, just because the science points us towards personalized medicine, and it clearly does, it doesn't mean that we're going to have personalized medicine tomorrow unless we do certain things. And healthcare, as we all know, is very complicated. So that's what I want you to think about as I go through this introduction. A definition of personalized medicine, according to the Personalized Medicine Coalition, looks like this. Personalized medicine is an evolving field with an emphasis on evolving, in which physicians use sophisticated molecular diagnostic tests to determine which medical treatments will work best for their patients. By combining the data, and it was noted that data is so important, and data is becoming less expensive today than ever before, especially in its aggregated form. And it has the key to unlock much of what we're talking about. So you combine the data with those tests with an individual's medical history, his or her circumstances, values, and then healthcare providers and patients can develop targeted treatment and especially prevention plans. In the United States, personalized and precision medicine are used interchangeably. But for me, personalized medicine goes a bit further than precision medicine because it really does put the patient at the center. What's driving personalized medicine are three things, obviously. The need for safer, more effective drugs, faster times to cure, and especially in this day and age, cost-effective, efficient healthcare. Now, one size doesn't fit all. We know that. And I mean, everybody in this room knows that. Actually, I would imagine every patient also knows it, because lots of drugs, lots of therapies don't work. And rather than go through trial and error, one-size-fits-all medicine, we're trying to get to an era where we would know in advance how to treat particular patients. And this slide, and I'm not going to go through every data point on it, but this slide shows that most therapies at present don't work. Cancer drugs, for example, are not effective 75% of the time. Clearly, we can and we should do much better if we can incorporate diagnostics into the therapies that we're prescribing. Also, therapies are the fourth leading cause of death, ineffective therapies, I should say, are the fourth largest cause of death in the United States, leading to over 2 million adverse drug reactions. This is something we need to obviously improve on. And one way to improve on it is to know in advance how to treat patients with effective medicines and not through trial and error and just happen to see if abacavir, for example, works on an AIDS patient without a test to know in advance it could kill you. Now we have that test, and we can prescribe abacavir to AIDS patients. This is an example, obviously, of personalized medicine in infectious diseases, and I guess it's about now 5, 8, 10 years that we've had that development. And it really was a major breakthrough for personalized medicine, demonstrating its importance and efficacy. The benefits of personalized medicine are these. First, it shifts the emphasis of medicine from reaction to prevention. If we can do that, we can make the system much more efficient. It directs targeted therapy and reduces, as I said, trial and error medicine, reduces adverse drug reactions. It can reveal additional targets for uses of medicines, and we'll be hearing more about that in a few minutes, and how that can happen. It increases patient adherence to treatment. Patients obviously don't like therapies that make them feel worse than the original illness, and therefore they stop taking their medicine, and so we can do better in that regard as well. We can also reduce high-risk invasive testing by using blood biopsies instead of tissue biopsies. Also something that patients very much enjoy, and they're also lowering the costs of healthcare. And then overall, as I'll show, we can, it is my contention, and it is only a contention at this point, help reduce the costs of healthcare systemically, which is why we need to explain what we're doing, especially to the governments around the world, who, if I may say so, who remain skeptical about personalized medicine because they assume, based on experience, that it's just going to raise the costs, even if it does provide better clinical outcomes. So our goal is to show, through the development of evidence, that you can get both better outcomes and lower systemic costs over time if you make the system more efficient. So as I said, personalized medicine improves care. So this is my second favorite slide. The first one was the Hippocrates quote, and this is my second favorite. This shows how personalized medicine works. Whereas once upon a time, we referred to diseases of the blood 60 years ago, not that long ago in human history. It was after World War II. 5-year survival rate was 0. But when we could molecularly define leukemia and lymphoma, and diagnose it accurately, we improved the 5-year survival rate of what was called diseases of the blood to 70% in the current era. So that's how personalized medicine actually works. Get the right diagnosis before you treat. And you can only get the right diagnosis before you treat if you have diagnosis built into the system, and that we invest in getting better diagnosis. This slide also shows the same thing. Whereas in 1984, there was only one known mutation for lung cancer. Today, as you can see on the slide at the lower right, there are multiple analyses of lung cancer, and each one has a different therapy linked to it. And lung cancer patients now have a variety of drugs to choose among, which has led to longer survival rates in what had been a death sentence. So personalized medicine works. This is another slide that shows the same thing in chronic myelogenous leukemia, where one drug increased survival rate from 31 to 89%. Same in metastatic colorectal cancer, breast cancer, Herceptin, which is still the poster child of personalized medicine. It works for women who overexpress the HER2 protein, and doesn't work in other women, but knowing that has led to great improvements in treatment of breast cancer. But it's not only cancer. Cystic fibrosis, there's a drug called Kalydeco, which works for particular cystic fibrosis patients who have a specific mutation. Doesn't unfortunately work for others, but knowing that has made this terrible disease one that's now more or less manageable for cystic fibrosis patients. Personalized medicine works. This is another example of how personalized medicine can work. Plavix will not work for some patients who have a particular mutation. FDA has recommended genetic testing to make sure that patients will benefit from the prescription of clopidogrel. Unfortunately, and I'll get to this in a minute, it's not often prescribed because it's complicated, it's harder, it's expensive, more expensive to prescribe a test. And so some physicians, not everywhere, but some physicians will just, go with the flow, as it were. So this era requires a lot of education, a lot of hard work to move us from the science to implementation. It's my contention that personalized medicine makes the healthcare system more efficient. If we knew in advance not to prescribe particular drugs to patients for whom they will not work, we could save the amount of money on the right in the United States. But we obviously don't know. And my exhortation to those I speak is, let's find out. Let's invest in diagnostics. Let's employ those diagnostics once they're developed to get the right treatment for the right patient at the right time. And that is the mantra of personalized medicine. And that only really goes back to 2003 when the human genome was first mapped. Chemotherapy reduction in breast cancer following a simple test can lead to a 34% reduction in cost. Never mind, the chemotherapy is not prescribed. It was just recently a major clinical trial released at ASCO that showed that as much as 90% of chemotherapy prescribed for women with breast cancer to prevent recurrence is unnecessary. Think about that. That's, that is just a dramatic example of saving lives, saving money, and improving healthcare. It took a long, long time and a lot of effort to get to that. A controlled randomized clinical trial was necessary to demonstrate to the medical establishment that they should prescribe either Mammoprint or Oncotype DX to test if the breast cancer would recur. Our contention is that maybe we don't need controlled randomized clinical trial to prove that any particular diagnostic works, that we can and should also use real-world evidence to figure this out. So we can get cost savings in breast cancer by using tests for HER2, for example. We can prevent strokes if we accurately and appropriately prescribe warfarin, something that's not usually done because there's not enough evidence to move doctors from, especially in the United States, from where they are today to where we might like them to go. But we need more education about giving people alternatives and ways to think about how to understand medicine, going back to the Hippocrates quote that people are different and we've got to understand those differences to make personalized medicine, or to make medicine work. Eventually, our goal is this should just be the way the medicine is. We don't call it personalized medicine. You don't have personalized medicine here and medicine here. It's all got to be personalized. And again, the key variable here is we're getting the tools to do that. And we're getting data being developed. And we're getting people also talking about machine learning, for example, and artificial intelligence that can speed up the ability to understand individual variation in ways that we have not before. So let me shift gears and just talk about how personalized medicine is transforming healthcare. This is a slide that shows the number of drugs that FDA has approved that have pharmacogenomic information on their labels. That is to say, advice to physicians on how to prescribe selected medicines, especially in cancer. So in 2008, the first time I think I came to Germany to give a talk, there were 5 drugs that had pharmacogenomics in their label. Today, there are over 151, and 1 in 4 drugs approved by FDA is a so-called personalized medicine. It's also important, and I think we'll hear more about this in a few minutes, that the pharmaceutical industry continue to invest in developing drugs for which there's no real good business model, because they're talking about developing drugs for selected populations. As you might imagine, 10 years ago, or maybe 15 years ago, most pharmaceutical companies, with the exception of Roche, would have preferred to sell one drug to everybody. It didn't work out that well because it doesn't work. So there's a shift, and the pharmaceutical industry is learning today that it can still make money based on targeting selected populations. And this slide shows how companion diagnostics are, at least in 2015, a $25 billion industry. And you can see the drugs on the right and their market share. As I said, FDA is, the industry is committed to the field. We did a survey of the current, or the pipeline, of about a year or 2 ago, and 73% of self-reporting from the pharmaceutical industry said 73% of the oncology drugs in development were personalized, had a companion diagnostic strategy linked to them, and 42% of all drugs had a companion diagnostic strategy associated with the development of particular therapeutics. So the industry has moved from a one-size-fits-all world to one of targeted therapy. I think the industry is actually ahead of the medical establishment, which is, for its own reasons, a little bit resistant, and far ahead of governments and payers who unfortunately remain skeptical. They wisely want to see the evidence or experience the change before they commit investments of scarce resources into something they don't particularly understand. As I said, in the interest of time, I'm going to go a little more quickly, but FDA is pushing this along. In 2005, only 5% of the drugs were personalized. Last year, over a quarter of their approvals were personalized medicine. There are over 65,000 diagnostic genetic tests on the market, and more are being developed every day. Unfortunately, they're not regulated as well as we would like, but many of them are valuable, and they are becoming a much bigger part of healthcare. They didn't exist 15 or they existed, but not to the degree that we see today. So how is personalized medicine going to affect healthcare? And here I'm just going to give you some top-line things to think about and that I hope will resonate in all of your lives. The first thing is that changing the role of patients. Patients are now much better informed. They're thinking about what their genetic makeup is. They're asking questions, sometimes inappropriately, about inheritance. And they're bringing much more to the equation, asking the question, is this going to work for me? Actually, I think that when the patient comes to the physician and says, you're prescribing A, B, C, or D, but is it going to work for me? We'll know we're in the era of personalized medicine. And that's probably not that far off as people begin to understand the significance of these new technologies and the significance of whether something works or not. So it also is changing the role of the healthcare provider. The healthcare provider no longer can practice medicine without sophisticated diagnostics, which are, as I showed in the slide on diseases of the blood, depends upon a sophisticated nosology of medicine that didn't exist before, and that is the key to to progress in medicine. There's obviously going to be an expanded role for pharmacists and genetic counselors, and I think most importantly and most challengingly, we are going to be linked by different data systems, and that we're going to have to be much more plugged in than we ever have been before. And so the key is going to be to use information technology to inform decision-making. And that obviously is going to be challenging to, and it is challenging to systems all over the world that want to incorporate personalized medicine. Requires a significant upfront investment of resources, intellectual capital, and a willingness to make the changes that are necessary to build the infrastructure that's needed. This, too, doesn't just fall out of a tree. Payers, in my opinion, are the key. Because if we don't want to pay for something, chances are we're not going to get it. And there is therefore incumbent on the pharmaceutical industry and others the need to develop the evidence that's necessary to convince the payer, and I say payers, but outside of the United States, we're also talking about governments, to be willing to pay for diagnostic tests, to seek to inform better treatment, and to perhaps even use strategies to limit reimbursement for medicines that don't work. So I think the payer is the key. I think the patient and the health providers all have to seek change. So to summarize and in conclusion, what are the barriers to realizing personalized medicine? Well, the first barrier I haven't talked about very much, but I don't want to ignore. The first barrier is we need better science and we need better understanding of biology. Second, we need a better regulatory system, especially in the United States, where diagnostics, for reasons I can't go into because I don't have all day, are confused. Let's leave it at that. We need better coverage and reimbursement strategies that focus on paying not for volume, but for value. We need less discussion about that treatment costs too much and more about what it does. And we need a willingness to target those treatments to patients that will work. Clinical adoption, even when all this happens, again, doesn't follow the night to day. We need better education of our workforces. We need patient engagement and patient protections, especially privacy protections, or patients will be resistant to integrating personalized medicine. Again, we need evidence generation to show that it works, and we need institutions willing to make the changes that are necessary to incorporate the new science, the new technology into better outcomes for patients, and I would argue more efficient and less expensive healthcare systems. So let's see you think I'd learn how to do this after 30 minutes. So the future of medicine relies on scientific knowledge, and it will lead to, as we'll hear in a few minutes, new drugs and new therapies. The cost of sequencing is declining rapidly. This should open new doors, and it's pretty clear that genetic and genomic testing is going to play a more significant role in drug development and especially patient care. I'd like to leave you with this thought from the CEO of a Cambridge, Massachusetts biotechnology company who was asked to explain personalized medicine against some resistance that many people still have, that it won't work. And her point is, we don't get a choice. Biology is complicated. We have to, as she said, just work with it. So thank you for your time and attention late in the afternoon. And I, again, really appreciate the opportunity to have given this introductory talk. So thank you.
You mentioned that yes. I mentioned that in the future we need a lot of education. So what do you think would be the most important instruments for this education? Would it be education at universities or more in the postdoctoral stadium?
Yes, well, I think the education in the universities is developing rapidly, and I'm really impressed when I met Professor Mons, or when I go around, and you'll hear from Dr. Stort tomorrow from Mayo Clinic. People are really, in the university world, really focusing on this because they see it leads to better outcomes. Where I think we need more education is among governments and payers and hospital systems, so that they be willing to make the changes that are necessary to put in place the new science which is so rapidly developing. One of the things I've learned is that science moves fast. Governments move, let's put it charitably, more slowly.
Thank you. Are there? Yes, Professor Mons.
I found it interesting, your figure that drugs approved by the FDA jumped up in a couple of years from 5% to 25% on an individualized basis. Is this mainly cancer or also drugs?
It's mainly
outside?
cancer, but as I tried to indicate, not only cancer. Cancer, it's been discovered as a genetic disease, so they're not going to get any drugs approved that don't have a targeted strategy. But it's not only cancer.
Yeah, I know in my field, some of the hepatitis C regimen, in particular in the US, they are only approved as genetic pretesting.
Correct, and those drugs for Hep C are included in those figures.
Oh, thank you.
But I would also give a shout out to FDA. FDA is encouraging the industry to develop safer and more effective medicines, and the only way they can do that is through a targeted strategy. So the industry pays attention, and FDA has really been a catalyst for change.
So another question.
Thank you very much for this. No, yet. Thank you very much for this overwhelming and optimistic vision of how personalized medicine will work in the future. I would be interested whether you think that there are different kinds of diseases that would be more or less suitable to be treated with personalized techniques?
Well, that follows the question a moment ago. Obviously, cancer is a genetic disease, and the treatments are going to have to be personalized. But I'd like to believe that Hippocrates was right. You know, the patient's bringing something to the equation. Only when we can figure that out are we really able to really treat him or her well. We can't look at the patient and see a disease. You have to look at a patient and see the interaction between the patient and that disease, whether it's in cardiology. And I think if we're going to make inroads in mental illness, for example, we're truly going to have to understand that schizophrenia, for example, is probably not one disease. It's expressing itself differently in every patient. And we're probably a long way from understanding that, but we need more investment in science so we can figure out how to actually personalize treatment. The days of treating patients with one-size-fits-all medicine are probably over. I mean, we've probably picked that low-hanging fruit.
Thank you for setting the scene so beautifully. The sentence that struck me was that we should be paying for value rather than for volume. And how do we define value, and how do we need to change our evaluation system in order to capture that value for the health system, but also for patients?
Well, as you know, that's a really difficult assignment, but it begins with a willingness to move away from actually paying for volume and to be able to incorporate evidence of, say, long-term survival and pay more for drugs that, quote unquote, cure a disease rather than, say, just extend life for a month or so. So we really need to be very sophisticated about how we do that. And we're a long way from that at the moment because people essentially don't agree. And one of the things my coalition does is try to bring these alternative points of view together to see if we can't make progress in thinking about paying for value as opposed to volume. And it's almost become a cliche that we need to do that now. But nevertheless, some cliches have reason to exist because we more or less do pay for volume now.
Okay, thank you again
So
for the
thank you.
fantastic presentation. And I think there surely will be some more discussion during the coffee break. And now